First, I would like to welcome our international foot and ankle surgeon from Austria, Dr. Ernst Orthner, founder of KBH Mission, and also Mrs. Veronica, Secretary of KBH Mission. And I welcome Mr. Bright from South India Regional Head Endolite. And also next I welcome our Senior Consultant Dr. Jayapal, our Director Dr. Parthiban, Mrs. Rekha Parthiban, Dr. Ramsa, Dr. Giridharan sir, Dr. Vigneshwaran sir, Residential Doctor, OT staff, physiotherapists, nursing head and team, and admin staff, and also the videography and photography person. I welcome everyone in this program. I request our Director to honor and give a bouquet to our chief guest, Dr. Ernst Orthner. I request our Managing Director, Mrs. Rekha Parthiban, to honor and give a bouquet to Mrs. Veronica. Our Director Dr. Parthiban to give a presentation about Indian scenario of foot and ankle.
This is on our Facebook page also, sir. Yes. Like foot and ankle, I just wanted to give a brief this thing for all the audience present here. These are the variety of different conditions what can be there. Pointer. Some of the things like a flat foot on the top, what you see on the corner, this is a Alex Varus. These two cases, this is a Charco foot, that's a Alex Valgus. These are the variety of cases what we keep seeing here. And India will be the diabetic capital by 2030 as per studies. Approximately 30% of the diabetic population are at the risk of developing the diabetic foot. So that's the need for the need to start a specialty unit for a foot and ankle clinic. That's the reason why we started this. We started this foot and ankle clinic on April 14th. This year, sir. And this, we run it on every Tuesday and Thursday between 3 to 5 p.m. And this was inaugurated by Dr. Ramesh Babu. He was president of the Tamil Nadu Orthopedic Association, and he has his own hospital and the director of Spot Hospital. He came and inaugurated the foot and ankle clinic for us. That's the time when we started our shockwave therapy as well. And we got associated with this company by name Foot Pro, sir. What you saw at the downstairs. They make the custom orthotics. So this is when I was there with Professor Pete Interman. Sir was with him last couple of weeks back, it seems. Sir met Interman. And this is Dr. Selin, sir, from Duke. So this 8th annual Parik Indo-US Foot and Ankle Conference, we did it in Chennai. This was last year, January 6 to 8. And this IFS Con, we recently did this IFS Con meeting now. And I've been elected as the executive committee member for the Indian Foot and Ankle Society. This is Dr. Thomas Lee, sir. Some of the cases what we commonly see and what are the cases we have operated. This is one of the patient, a 35 years lady, the deformity of the great toe. That's Alex Valgus. This is some of the non-operative managements, like you can give them a pads, spacers, orthosis, night splints. This is one of my earlier cases, sir, when I did a crescentric osteotomy, then fixed with wires. This is the pre and the post. This is one of the cases of a pes planus. You can see the heel valgus there, single leg heel raise. Still the foot is supple. So we went and did this is for the normal people to understand what does it mean by a flat foot and what does it mean by a normal arch. This is a Salzman view here. You can see the heel in so much valgus. You can see the talar rotation there. In early stages, we treated conservative by means of arch supports and exercises. When the deformity is flexible, we do a joint sparing procedures like tendon transfers and calcaneal osteotomy, and then when it's fixed, we do a triple arthrodesis. There's a pre and post in one of the cases. Every time, it doesn't mean that we need to get the arch there. Case 2, it's a 54 years female, pain and deformity in the right foot for 10 years. This premise with Alex varus and arthritis of the talonavicular joint she had. You can see the cyst, degenerative cysts there. This is after a calcaneal osteotomy and a talonavicular fusion. And as well as an Alex varus correction, it was more of a soft tissue procedure. One of the cases, a football player with complaints of pain, recurrent injury to the right ankle. Here a lateral ligament instability. You can see on the stress view how the talus is tilting there. Almost every ankle sprain usually we treat with physiotherapy. Initially, that's the rehabilitation program. Phase 1 is going to be rise. That's rest, ice, compression and elevation. And phase 2 is going to be restore range of movement and strength and functional training with gradual return to support. That's a phase 3. When these things, conservative management failed, we do a modified rostrum. That's the surgery what we do. We do a double breasting of the ATFL ligament. This is one of the common injury what any foot and ankle surgeon sees. Chronic instability requires a reconstruction of the lateral ligaments, and gold standard is rostrum. This is one of the case 4, that's a 60 years male, pain in the left ankle, 10 years on and off, retrocalcaneal area. This is the bump, what you see there. This is the degenerative tendon there. After removing all the degenerative material and the Haglund's bump is resected, then the tendon is put back there with a suture anchor. This is case 5 is one of the common thing which is missed. That's a Lisfranc injury. Professional sports person, pain, swelling, difficulty in walking, followed with injury 1 year back. Treated by friend, referred to me for further management. So it was a missed Lisfranc basically. Whenever you see a ecchymosis on the plantar side, you have to be really serious that there is a more significant injury. This was a normal X-ray, and compared to a standing X-ray, you can see the space widening there. Mostly it requires a close reduction internal fixation or a ORAF without rigid anatomical fixation. Arthritic foot with progressive collapse of the medial long ligament arch. This is what we did, the reduction, and then we put a couple of screws there. This went on to heal. This is a case 6, a 57 years old female, complains of pain and gross deformity in the left foot for past 10 years. Alex varus deformity with arthritis of the first MTP joint. This was her foot when she came in. We did a first MTP fusion. This was a post-operative clinical photograph. This one we keep seeing very commonly, sir, like native treated. Calcaneal fracture, went in for a native treatment, and then finally coming to us presenting quite very late. You can see the height decreased, so much arthritis there. And he had a lateral impingement also. Sorry about the. So this, we did a distraction arthrodesis. Took a graft from the iliac crest, a couple of screws to get back the height. This is one more, this is a Charcot foot basically, 65 years, male, trivial injury to the left foot, known case of DM. This was the initial X-ray what he went to another orthopedic surgeon there. This was initially treated conservatively. You can see the chip there. There is some amount of instability happening there. You can see a chip. This was 1 month post-conservative. You can see that slowly the foot is dismantling, and 3 months post-treatment. When he landed with us, it was this is the thing what we saw when he came in to us. This wound was little serious discharge was there. We treated it conservative and everything. Once the wound healed, then we went in. This was his weight-bearing X-rays. You can see the break in the midfoot. The total disorganization is the charcoal. Beam screws and all reduced and he settled, sir. This is present trauma to right ankle treated conservative elsewhere. She presents to us with complaints of pain and inability to bear weight over the right lower limb. This was another case of a charcoal ankle. This lady didn't have any infection when she presented. We went in and did a fusion like this. This went on to heal. This is her clinical photograph now. She's a professor known of the college here, close by. This is the variety of things what we keep seeing in our population regularly, sir. This is the Indian scenario what we keep seeing this commonly. Thank you, sir. And one more thing is, we have 2 meetings every year what it happens for the foot and ankle. So one is the Indo-US foot and ankle meet. This happens every year in January, first week. Dr. Selen comes from US and he usually brings 3 or 4 foreign faculties along with him. Usually this is a 3 or 4 days meeting, usually basically 4 days it happens. 2 days live surgeries happens on this. This happens all around India. This time it's January 5th to 8th. I'm also part of the faculty there. This is going to happen in Bombay this time, 5th to 8th. And there's one more meeting which happens in the mid-year, that is the IFS, called the Indian Foot and Ankle Society meeting. This happens every July, this happens. This also keeps going around everywhere. The next meeting is going to be in Delhi. The IFS meeting is going to be in Delhi. Next year. This year just got finished now. So next year meeting is going to be in Delhi.
Sir, for your practical speech. And next, I would like to request our chief guest, Dr. Ernst Orthner, to give a special speech to us.
Thank you very much for the invitation and congratulations for the foot clinic. By history, I come from Austria. Many think Austria is Australia, but when the other part of the world, and in Europe, a very small country, always say Austria has 8 million inhabitants, half of Delhi, and that's our whole country. But I do foot and ankle surgery now more than 30 years now, and specialized in foot and ankle about more than 20 years. Come from trauma, not an orthopedic. We have in Austria we have trauma and orthopedic surgery is totally divided. Now we came together last year, and I come from trauma, and we had always a problem. Trauma surgery was ankle fractures, pylon fractures, calcaneus fractures, talus fractures, and ended in the forefoot. And orthopedic surgery was hammer toes and bunions. Bunion is has been the main profession in Austria, because in Europe it's totally different to here. I've been here in India now the 20th time I'm in India, and I've seen only little number of bunions. It's really rare. In Austria it's very common. It depends on the shoe wear, and how we are living. And I was starting with foot and ankle. I started with foot and ankle when I was a resident. I was a resident in the university clinic, and it was a situation. We had a team for knee, we had a team for shoulder, we had a team for hand, and we had a team for hip and for spine. But no one did take care of feet. And I come from a rural area. I come not from a big city, I come from a rural area, and then if you come from a rural area to a big city, you're always forgotten. I said, okay, when I take care to knee, everyone is taking for knee. I said, okay, I take care on the feet. And I was interested in feet, and then I did find that almost nothing was known on the feet. No one interest was on the feet, and then I started. And that was the beginning, and then I started. And I remember when I did my first bunion, my first bunion surgery was 1989. It's now about 30 years ago. And I came back from a meeting from the States, and never so dangerous. as when you come back from a meeting, and I did see in the States how it was done. I had a textbook, I did make my incision, but on the textbooks there was nothing written on the soft tissue procedures, and I tried to shift the head on the lateral side, it didn't move, and after 4 weeks it looked the same like at the beginning. I thought it was not very successful at the beginning, and then I said I must take care more of this. And then it was, and the beginning was then about, was it 20 years ago, because then we started to develop new implants. And you remember 30 years ago, what we did in foot surgery, we made some operations, some osteotomies, take K-wires, that it was. So it was no special. And about 20 years ago, in trauma surgery, there came plates with locking screws on the market. And there was a big discussion in trauma, if you have a tibia fracture, a femur fracture, does it make sense to take plates with locking screws? It's really necessary to have these special plates. And I did see this idea and said, okay, in feet, it could be necessary, because when you have so many bones there, in one foot, we have 26 different bones, and a lot of 54 joints one said is in a foot. That means if you want to combine and fix it, then it would be an advantage to start with the special plates. So we designed 1999 a special foot plate system. It's still on the market. It has been produced 1999. It's still sold in the market. And it was the beginning of a really new era in foot surgery, because then we started with it. Now, if you look on the market, there exist 10 or 15 companies who are selling. And we always make a meeting in Munich each year, and foot and ankle meeting with mostly 400 to 500 participants. And I remember when I was first time on these meetings, there were exhibitions with only 5 companies. And all companies did sell new shoes. No implants, nothing. And last year we had about 60 companies at this meeting. That means that you can imagine how this market was evolving. And that was the beginning. And of course we changed a lot of procedures, we changed a lot of methods. And we could find that many of the procedures we now do are very old methods. Sometimes they're 100 years old, but at this time they didn't have good implants. That's the complication rate very high. Yeah? For example, the bunion surgery, we take the lapidus arthrodesis. Lapidus fusion is a fusion of the TMT1 joint, the tarsometatarsal 1 joint. And when I started doing lapidus, at this time, the post-operative treatment was the patient did get a cast, he get crutches, it was 6 weeks of non-weight bearing. And meanwhile, we take special plates, and the patient is starting with walking. Immediately after the operation without crutches, he is weight bearing on the heel, and after 3 to 4 weeks, he is full weight bearing with a normal shoe. But you must imagine, from 6 weeks with crutches and non-weight bearing to about 3 weeks with a special shoe and full weight bearing from the first day on. It's a totally different. That was the development of the last 20 years. And one of the ideas we had started with total ankle in 1999. Total ankle is still, even in Europe, not so popular like total hips and knees. In Germany, for example, I've done about 150, 160,000 total knees a year and 800 total ankles. You must imagine. But the situation is that the total ankles have the same age like total knees. The first total knee, which was cemented, was done 1972, I think so, and the first total ankle was the same year. And that was developed from the same guys who made total knees. It was developed to total ankles. And it changed the idea from a total knee to a total ankle. But at the beginning they said, I think it works, but they did see that it does not work. It really was the problem. And then at the beginning it was great, and then after 3-4 years they did see that it doesn't hold, it gets loose and so on, the results were bad. And then it's not possible to make a total ankle. And then it was about 1985, 86, Kofod from Denmark developed a new total ankle. It's the star prosthesis. Star prosthesis star prosthesis was developed 86 or about this. It's still on the market. And when one says total ankle does not work, you have a product which is 30 years on the market, it doesn't fit together. Because if it does not work, it would not be dropped out of the market. And then I started by myself 1999 with the first total ankle. It was a star prosthesis, but I was not very satisfied with the star prosthesis because of the instruments and the configuration. And then after then I went to the Integra prosthesis. I was one of the first users of the Integra prosthesis. It's from Hintermann, from Bert Hintermann. You did see here. He developed it, and yes, it was the same. I did take it, and it was the same. I didn't not good press fit. I was not satisfied, and the Integra prosthesis is sold very much on the market now. But now it's on the market in the fourth generation. There has been a lot of changes in it, and always good results. And I don't believe if you have always good results, and each third or fourth years you see a change. And then after 4 or 5 years of total ankles, I said, let's think on a new total ankle. And the problem was that on one side the total ankle, the longevity was not so good, and the other side what I was seeing was that the range of motion after a total ankle didn't change a lot. And that it was always the same. If the foot was stiff before, it was stiff after it, and the change was about, in the literature is written, the increasing of range of motion is 0 to 5%. 0 to 5 degrees, that's what's written. That's almost nothing. Yeah? And then I collected the team. We were 4, and each of us did take another implant. One was Star, one was Integra, one was Salto. I was the Salto man, and one was Pudel Papas. And then we reduced it to 3, and then we were starting to develop a new implant. But we said we must change the idea on this implant and make something different. And it was terrible. We were all between 50 and 60, and if 3 or 4 come together in the age between 50 and 60, it's difficult to make some planning, because each idea is the best one, and of something we did forget, and sometimes we had a meeting and said, oh, looking at our records, 2 years ago we have solved this problem. But after 5 years it was finished. We were really working 5 years on the implant, and that's now the result of this implant. I take this implant now for 10 years. We have 10 years results out of it, and the result seems really to be good. When you look back, 2009, Pascal Ripstein is a guy from Switzerland. He's a famous foot and ankle surgeon who is in Switzerland, in Zurich, and he made the mobility prosthesis. Mobility is from another prosthesis. It's not on the market anymore. It's taken off. Mobility. There was agility was by history debut. Yes. Agility was the US implant. Agility was a special implant which was designed in the US. But it was impossible to sell it in Europe, because the results of the agility was not very good, but it was the only implant what approved in the States, and that means if one wanted to have a total ankle, he had to use the agility, and the sequel of the agility was the mobility, and he was one of the developers of the mobility, and they visited him in 2009. And said, okay, let's look how it is. And then asked it to him, I know him very well, what is in your opinion a good indication for a total ankle arthroplasty? He said, yes, the patient should have a good range of motion. That means it doesn't become better. Yeah? You must have a stable situation, not only on the slight instability, no big deformity, only little malalignment. And the patient should be elder than 60 years and not very active. And I said to him, good range of motion, stable situation, no big deformity, only little malalignment. This patient doesn't need a total ankle. And that would mean that about 80% of my patients would get a fusion or something else. Yeah. But since 2008, my fusion rate has gone down to less than 5%. I do almost all my cases now with a total angle. And that's a real situation. Yeah? That are all cases which did get a total angle. And if you look here, that's for example, that's a lady. During the operation, she was 41. It's always a question, which is the age, but she had this avascular necrosis of the tibia and of the talus, and she had it both sides, because she had to get a high doses of cortisone for a year because of an unknown problem, and then to get really avascular necrosis of tibia and talus on both sides. It's now 13 years ago, and we did on both sides a total angle, and the total angle is still in place, still is working. Yeah. But if you look here, it's the subluxation, or I say you don't know where's the ankle joint and so on. That's all cases. Was this malalignment about almost 30 degrees of varus? Yeah. That all did get total angles. That's illusion. Yeah? And this is only possible. That's a new idea. If you did look at the agility, I was once in the States and was with an agility. With the agility, that was the situation that the patient was fixed in the frame, and with an external fixator, fixed in the frame, and then was cut out the box of the ankle joint, and this box was put in the agility. But no one did take care of what is really with the joint.
How much of a bone it was removed?
It was only a new implant, but it was not changed on the foot. And the problem is, almost all feet who have an arthrosis have not only an arthrosis, they have additional problems. Malalignment, shortening on one side, loosening on the other side. And our idea was, we can really treat all these cases when we cure all the additional problems, and at the end you have an almost normal foot, and the only thing what is not in the place is a normal joint. That means you must correct the foot, when it's possible, it's done in one stage. You must do a lot of additional procedures sometimes to correct it, then it can be done. What is a must for a good implant? It should cover almost all intra-articular problems, of course. And the instrumentation should be standardized, even in tough cases, because if it's standardized, you have a tough case, even still you can do it. If you have an instrumentation which is very complicated, or it's not very logically, so it's very difficult, because you're always dealing with the instruments, not with the patient. It's the same as for the nurses. If you have a very, very complicated instrumentation, it's difficult for the nurses, and then you're dealing more with the procedure and not with the case. That it is. It should be done in the standardized ways. It should be simple and not more than 2 to 3 trays. Bone loss should be minimal, and what is important, revision should be possible. That should be. And if you look here, that's not our implant. That's another implant. Yeah, that's a US implant. Yeah, it's an in-bone or in-vision prosthesis. I take it sometimes for revision of total ankle. But you see here, the foot is fixed in a frame. That's a sterilized frame. Yeah. You see a lot of K-wires. You need for this implant up to 14 K-wires, which were dropped off. Yeah? If you know what the price of one K-wire you drop off, you can imagine. And that's the instrument. Yeah? These are 15 trays. It's unbelievable. Yeah? You must imagine you have an implant where you need 15 different trays and so many. It's in tough cases, of course, it's sometimes necessary, but it's not a standard procedure. If you have a revision of a revision, that makes sense, but not as a standard instrumentation. But that it is, and we always say we should make it simple and this is cost effective. But the indication, what is always the question, what is the indication for a total angle? Yeah? And the indication is not this or this, it's always the same. Arthrosis and pain. because if the patient has no pain, he doesn't need a treatment. Let him alone. Yeah. But the difference between hip and knee is that almost all patients have additional problems. Yeah. The prosthesis must give us the option to correct all these additional problems. And that's a big difference. If you're making total hips, a total hip is a very, very good procedure. Total hip is a ball and socket joint. Yeah, it's flexible, and you know if you make a total hip, you make it in a varus of about 10 or 15 or 20 degrees. It still works very often. The patient is happy. If you make a total ankle with 15 or 20 degrees of varus, you get a call from the lawyer, not from the patient, because it doesn't work. It's not a total ankle. It's a non-forgiving procedure. That's the problem. But we must learn to treat these additional problems. That means makes not sense to say I start now with total ankle, but I have no experience in foot and ankle surgery. You must really know everything how to do it. Yeah? And the other question is, if you look in the market, almost all implants say we designed an anatomic prosthesis. It's a good for selling. I make an anatomic prosthesis. It means it's like the same. We know it from knee. Anatomic prosthesis of the knee don't work so good. Non-anatomic prosthesis work better than the anatomic prosthesis. But in the ankle we have still anatomic prosthesis. But if you look here, that's our foot. And if you look here, the external torsion of the distal tibia varies between 69 and 99 degrees. That means if you look on our leg, we have an internal torsion of the femur. The internal torsion of the femur is an average 24 degrees, and the external torsion of the tibia is about 35 degrees. But the variation of this torsion is 30 degrees. It's the same as with the obliquity of the subtalar joint. That means the axes are totally oblique in the room, and the subtalar joint and the ankle joints are working together like a cardan joint. And that makes it so difficult, because what anatomy do we have? Do we have the anatomy of 69 degrees or the anatomy of 99 degrees? And that was the next thing, but we cannot design an anatomic prosthesis because we have no standard anatomy in the ankle joint. You have to design joint which works for different patients, but we must correct the patient to the prosthesis, and not the prosthesis to the patient. That was the things what we were thinking. Indication in general, and that is mostly a trauma. About 70% of our cases are trauma, and others you see here. Primary is rare. It's totally different to hip and knee. In hip you have about 95%, and the knee is the same 95% spontaneous, and only most traumas are rare. But in the ankle it's totally different. Why it is we don't know, because the smallest big joint is the ankle joint. It's only 6 square centimeters, and they have the most weight in the ankle. Yeah, and still it's cartilage in the ankle is much thinner than in the knee and in the hip, but still it's rare. That's the situation. Absolute contraindication for total ankle is, of course, an active infection or not infect-free for less than 12 months. That's always a question. What we do if the patient had an infection. For me, it's always the same. I look not only that he has no infection for more than 12 months. The other side is I'm looking which germ is inside. If you have a staphylococci inside, the staphylococci don't stay in the joint, in the bones. They are killed. But pseudomonas, for example, can stay inside the bones. That makes it different. But the other side is avascular necrosis of the talus. Acute Charcot. Of course, you have seen the Charcot case from you. If you have such a case with an ankle joint, you had an ankle case. It would not be possible for a total ankle, because the Charcot, the bone is so soft. The question is, what is the do a total ankle in a heel Charcot, I've done one. It works. Yes, but not in an acute Charcot, but if you have a Charcot case, and the Charcot case has been treated conservatively or operatively, yeah, it's in its healed, he gets a normal bone again. And that's the problem is the Charcot has no sensitivity in the sole because of this polyneuropathy, and we don't know what has happened to the joint. But our patient now works for 4 or 5 years now. Yes, we have only one. Of course, a vascular problem. Of course, the patient should have at least 2 vessels. Okay. And if the bone stock is extremely bad, okay, it's a question, but it's really almost now. We have some weeks ago we did a case. It was totally dislocated joint, and we still put in a total ankle. It still works. Obese patient, more than 150 kilograms, and no immunosuppression. But if you see, that means you have almost all of the cases you can do with a total ankle. Yeah. But the more important question, if you think on a total ankle, is what is the additional problems? Not what is the problem of the ankle joint. Of course, you see the X-ray and say, oh, the damage that destroyed the ankle joint. Normal, you must cure it. But what are the other problems? Do you have a lateral instability? How is the leg axis? Do we have a deformity of the tibia? Do we have a medial instability? Yeah? Very often, if you have a lateral instability, you have a medial tightness. Because if it's lateral unstable, in the varus, it gets too short on the medial side. How correct it? If it's in the medial side too tight. Then we have a stiffness, and for me very important is how is the subtalar joint. So it's always a question, because in the literature it's written fusion and total ankle are similar. And if you have a foot which is totally flexible, there's only an isolated arthrosis of the ankle joint. These patients are really happy with the fusion. If you have a really mobile foot which is loose, yeah, and you have an isolated ankle arthrosis, and you fuse it, the patient will be happy because he has other joints, and these joints compensate the fusion. But if the patient has a subtalar arthrosis or the end arthrosis, shoulder arthrosis, and the malalignment of the hand foot, yeah, and you make in this case a fusion, this patient is not happy because then he feels the arthrosis and the other joints is the same, and then the next step is you make a tibio-talar calcanea fusion, and that's terrible because it's really a stiff hind foot. But if you have a totally stiff hind foot, the patient is unhappy. That's the best indications are the additional arthrosis. Cavus foot is terrible. Cavus foot by himself is terrible. By itself is terrible, and cavus foot with arthrosis is more terrible. That's really the worst thing what can happen. That's the toughest cases to make implants in cavus feet. That's really terrible. Flat foot is much better. If you have a flat foot like you showed it, we do it in 2 stages. We make in the first stage make a reconstruction of the tibialis posterior tendon and the calcaneus osteotomy, and in the second stage we make the total ankle. The reason is we try always to do everything in one stage. The only thing is the flat foot, not because if you make a flat foot, you must fix the foot in the other positions and to the total ankle. It means the post-operative fixation does not fit to the total ankle. That cannot be done in one stage. On the other side, what we do not in one step is additional subtalar fusion.
Flat foot means you do for stage 4.
There exists some cases you have a flat foot and an ankle arthrosis, but no arthrosis in the subtalar joint. When it's in the subtalar joint, then we make a reconstruction of the tendons and the calcaneus osteotomy and so on. And then in the second stage, we make a total ankle. But if you have an arthrosis of the ankle and of the subtalar joint and the flat foot, what happens in stage 4? Yeah, then we start with the subtalar fusion. But this subtalar fusion I make now from the posterior approach. Because there's a big risk if you make a subtalar fusion and a total ankle, that you get an avascular necrosis of the talus. Because you kill almost all the vessels of the talus. Yes. And for me, I always now make it poster approach the subtalar fusion because then that's the synastasis alone. And the synastasis is arteria canalis tarsi, and this artery is necessary for the talus. That means that's special cases. All others are done in one case. But how difficult it can be if you look here. So that's a total ankle, and if you look at this X-ray, you say, okay, medial malleolus is cut or it's broken, and there's a bone graft, and it's oblique. It's a terrible result. I always say, if you see this X-ray, you think, okay, the doctor didn't have a good day. Yeah? Because it's oblique and so on. But if you look here, it's the same case. Mine looks much better. It's the same case on the same day. And if you look at the axis, yeah, you see it's exactly on the axis. It's exact on the mechanical axis. That shows you how difficult.
You had a tibial fracture as well, or that's an osteoarthritis?
He had it. No, he had a tibial fracture. The history of the tibial fracture, and but that shows you on. If you go back here, you see if you make the adjustment to the axis of the tibia, of course you would make it perpendicular up here, yeah? But at the end, then it would be totally wrong. Yeah? That's the problem what you sometimes have. We decided, let's say we make our adjustment to the tibial axis. We make the adjustment to the center of the hip and the center of the knee. That's one of the solutions. We said, okay, we look on the mechanical axis of the leg, we make our tibial cut 90 degrees to the mechanical axis of the leg, not 90 degrees to the tibial axis. Yeah? And the other side is what is the second point what you can take, because for the positioning of the talar component, we said next is take the calcaneus and make first our tibial cut, resect our tibia, and then balance the hindfoot. Since we make some loosening on the medial side or shortening on the lateral side, bring the heel under the axis, and in this position we make the positioning of the talus. It means our reference points are hip, knee, and calcaneus. And that makes it sometimes very simple, especially in cuff damaged cases where you have a totally destroyed joint. You don't know where is my joint, where is my joint line. Don't take care of the joint line. You cut it out because the reference is hip, knee, and calcaneus. That was really, we learned it over time. It's really a key solution. And that's the situation of this case, you see, before, and that's the range of motion of the case after 3 months. Yeah? And it's really now some years ago, and it's really totally happy with this. Yeah? It's the importance of balancing. That is really the most important thing for me for total angles. It's balancing. Yeah? And if you look at this case, that's a mobility prosthesis. Yeah? And if you look here, it's not my case. Yeah? But you see, the positioning is not so bad. But it's, you see, the slight subluxation, but it mostly doesn't matter. But you see here is this fatigue fracture. Yeah? And you see, it's a, here you see some callus, that means fatigue fracture. It's not a fracture by the cut, by the horizontal cut. If it have been the horizontal cut, it must have been horizontal. Yeah? But it is not. And then we have learned in the old courses, yeah, if you have a non-union and a hypertrophic non-union, what you need is some stabilization. Stability. What you do, you make a screw. Yeah? Yeah. It was screwed. That was the result. The non-union was healed, and then it's subluxed. Then the question is, if you look here, what is the problem? Why does this case? Because the positioning of the tibia is not so bad. It's the center, it's in the axis, it's the same here, it's subluxus. Yeah? And if you look here, that's the axis of the prosthesis, that's the heel. That was the problem. Yeah? The surgeon didn't check that the calcaneus is on the wrong place. And that means this is a case which is not balanced. Yeah? That's for me the key. It's really balancing. Hindfoot alignment is wrong, yeah, but it's That's a prosthesis which is, I make my cut on the tibia, I make my cut on the talus, but I don't check the leg. I must adjust it to the leg and not to the ankle joint. That it is. That we decided the prosthesis with a flat surface to reduce the wear. And the prosthesis which is brought into the joint, but with additional procedures, the foot is adapted to this new situation. Yeah? This is according to the leg axis. This means center of the hip and center of the knee. Balancing is essential. Release of the joint is essential in bad range of motion. Yeah? And we have designed a special inlay with a small peg on it. It was always discussion, is the peg good or bad because of to get some polyethylene debris. But we didn't have any problems till now. But with this peg now, it's totally stable. So it means we can really make this joint very, very loose. That it's very good for the range of motion, yeah? And only little bundles. Yeah? And it's adjusted to the weight-bearing axis of the leg, not the resurfacing procedure. That's really, yeah. And if you look here, that it is. We have adjustment here, center of the hip, center of the knee, and you see here, that's a subtalar fusion. And you see here how oblique the cut is. Yeah? Very often the cut is oblique. Yeah? The joint of if you look here, yeah? It looks crazy. That's the axis of the leg, yeah? And that's the situation of the distal tibia. Yeah? And that you have a cut which is about more than 30 degrees. And of course you must make the second cut on the talus parallel to the first cut. Cut only on the medial side, almost nothing of the tibia, and on the lateral side, almost nothing of the talus, but then it fits. Yeah? Or if you look at these cases, yeah, so if you adjust it to the leg axis, or the tibia axis, you don't know where is the tibia axis in this case. And if you see with this situation, the adjustment is really very, very simple and easy. And that's the situation in this case because if you've seen it here, the range of motion preoperatively was 0, 10, 25. She had only 15 degrees of range of motion and had an equinus of 10 degrees. And that's the situation after the operation. Now she has about 50 degrees of 20 degrees of dorsal extension. And that's a big difference. Of course, yes, it's not a normal range of motion, but an equinus of 10 degrees, it's difficult to walk, but with this, it's easy to walk. Yeah? Inlay has different sizes, and that's how it looks like. That's a peg on it. We were discussing along, does it make sense to make such a peg or not? But you see it here. It's a round peg, but this is oval. That means it can move. It can move anterior and posterior, and that's a big advantage. It means during the operation it finds its place, and then we have seen that the motion is almost on the talar side and not on the tibial side. That means the inlay finds its place. Then it moves not very much. It moves mostly on the talar side. Yeah? And that's a typical salto prosthesis, yeah, you see. And if you have such a situation, the patient came and said, I have postoperative much pain on this day. Yesterday I was pain-free, and today I have made one step and I have terrible pain. Yeah? It's always the same. It's a broken inlay. Yeah? You see it here. This inlay is back here. Yeah, the marker is back, and that's the situation. And that was a typical problem of the star and of the salto prosthesis, because they had thin inlays. Because of the design of the prosthesis, they had to make thin inlays, and the thin inlay had the tendency to break. We had 4 mm and 5 mm inlay did break in the salto, and the star prosthesis is the same as the mobility. And this start is 6. That's what the thinnest inlay is. Because of the design, we can make thicker inlays because of the situation. And this peg allows motion in all directions, but dislocation over time to medial, lateral, anterior, posterior, and rotations. That can be done. Yeah? I have done 283 saltos. Yeah? And we had 6 breakages of the inlays. It's a high number. 6 out of 300 means 2% of breakages. All were thin one, 4 millimeters, 5 millimeters, only one thicker one. And the star was the same, and the mobility was the same. You see, that's a typical, yeah, that's the mobility. You see the action of in here, what did happen here. Cystic break, yeah. Same again in the of salto in there, yeah. And the special feature of this prosthesis is the tunnel preparation. So tibial preparation is simple, it's a horizontal cut, next to linear. But the tunnel preparation in all prostheses are sometimes difficult. American prostheses sometimes have a flat cat. If you make a flat cat, you lose a lot of tailors. Yeah? And they also have a triangular cut. It's a posterior cut. Yeah? It's very difficult, especially if you have a flat tailors. If we make it over a K-wire, position the K-wire into tailors, and then make a reaming over this K-wire. Make it in one step. Yeah? That means if the ligaments are balanced, yeah, must be balanced, the continuous shift on the leg axis, and the tailors tilt then in the oblique position. Yeah? And then that means first you make a tibial cut, then you balance the joint. And if the joint is balanced, then you bring in the K-wire, it's a balanced position, parallel to the axis. But very often the K-wire is oblique intertailors, but over this oblique K-wire you make a horizontal cut. Show you it. Yeah? And that's, if you look at this case here, again, you see the trial is inside, yeah? And you see the lateral instability and the tilting and so on. Yeah? And in this case, you had to cut the medial side to balance the medial side and cut it on the lateral side. And then, with cutting it on both sides, you could balance the hind foot. In this balanced position, we brought in the K-wire. And you see now how oblique it is. And over this K-wire, you can over-ream it, and then it's parallel. And if you look here, we have one screw on the medial side and one thin K-wire on the lateral side, and some bone anchors for the ligaments. That's almost nothing for fixation. And if you make a bilateral ankle fracture with one K-wire and one screw, you get some problems sometimes. It's much good, but if it's balanced, it heals. Yeah. Yes. So show you how it is. Then the other side, if you have such a flat talus, the same. If such a flat talus, it's a big problem to make an operation. That's the salto prosthesis. Yeah. You see, that's the salto prosthesis. This is the shape of the salto prosthesis here. Yeah. And if you bring it in here, you see how deep gets the cut into the tailor neck because you have such a flat talus. And that's really a problem. And if you look at this case, that's a revision case. Yeah. Yeah. You see how minimized is the bone loss. That was a revision case. This is a subtalar fusion. And if you compare it to here, yeah, you see that was a primary operation, and then it was brought in a salto, and then it was revised with this. And you see, you almost lose no height in this situation. Let's think. Is this a video? Is this a video? Oh. You see it here, it's done over his back, yeah? And there you see how little is the loss of bone here in this situation. At least lose almost no bone on the tailor side. That's the advantage of this situation. That's this case, what you can see, yeah? And even in the revision cases, this can be done, yeah? In normal bone reaming is in one step, in very hard bone is done in 2 steps, yeah? If you look at this case, it's a good indication for total ankle, yeah. But the patient did get a total salto, and after some years he gets some cysts. Because of the cysts and pain in the cysts were removed, and after revision the cysts he get an infection. This chronic infection you see here, that was lost. Yeah. If you look at this situation here, yeah, you see how much bone has been lost here before. Then came the revision, and then was this situation. Yeah. And now it's a situation it's really tough to make a total ankle here because you have almost no talus anymore on the back side. And even in this case, yeah, you see it here, that's only what was left from the talus. And even in this case, it was possible here GN joint, yeah, to make a total angle. In this case, we come back with our K-wire retrograde, and then overream this K-wire from retrograde. How it looks like. And then you see that's a normal implant. There's a 12 millimeter inlay, and you see here it's almost no bone loss. Yeah. Even in this case, without any, it's a normal implant. It's not a special implant. It's a normal implant with 12 millimeter inlay. You could revise this case. Yeah. In other cases, this is a mobility. Again, we had to revise. You see, that was the problem of the patient. It was a totally oblique cut on the talus. It was the reason it was totally stiff. And of course, it was simple to revise because we do it antegrade. Yeah. All the same is balancing is essential. That is one of my most preferred slides. Yeah. Yeah. You must balance the joint. That's how you do it. Yeah. That's your personal experience, and you can do it. Yes. How you want. Yeah. You must be married very good, then you can do it this way. Because then if your wife jumps down, you get an accident. Yes. Additional procedures, you see, 101 cases, 106 cases. Yeah, the first 106 cases. And you see, almost all cases, an additional procedure was necessary. In 58, about half of the additional procedures were done for balancing. That means you make an adaptation of the joint, the artificial joint, to the leg. And adapt the leg and the ankle joint to the artificial joint. That it is. Not only we bring in, like the US systems, we bring in an implant and that it is. That's for me the keys. I'll show you at the end if you. It's a video, don't know. I hope. Yes, you see it's this case, yeah? And I think it's not a perfect indication for a total ankle. How's walking, yes? That's the X-ray, AP, it's a better side, because that's lateral. Yeah? And he has a situation, he has a big varus, big arthrosis, and a bad cables. That's the worst thing what you can have. And in this case, we revised and did all in one stage. We made a total ankle, did the lateral ligament reconstruction, made a medial malleolar osteotomy, length the tibialis posterior tendon, calcaneus osteotomy, and the fusion of the midfoot, the coil osteotomy. All in one stage. It was a 5-hour procedure. Yeah. That was during the operation. That is the lengthening of the tibialis posterior tendon, that's the cut, and so on. That's one of my most preferred slides. Had so many sutures that I couldn't find who is who, but at the end I did find who is who. And that's the final situation. And you see it here. It looks like a normal foot. Yeah. This foot was really totally adapted and was corrected. The foot was corrected, and in the corrected foot, the total ankle was brought. And that's, for me, that's the situation after 6 weeks. And what for me, must look here. In the medial side, we have corrected the whole foot. All. And there's an osteotomy of the medial malleolus, not a fracture, the osteotomy, with no fixation. It's unbelievable. If you make trauma, and they have a medial malleolar fracture with dislocation, and you don't fix it after an ankle fracture, you get big problems, and you get all have pain. But if it's balanced, it works. Yeah? And then you see, that's after 2 years, and you see, now the bone comes. And now, yeah? And now after, the patient was with us 5-year result now, it's still in place, and now it's healed. After 3 years, it was almost healed, and now after 5 years, it's totally healed. And that's the situation. And he's totally happy. That means if you don't balance this foot with a total ankle, you cannot cure it. You cannot cure the foot and add a total ankle. That is the key. And that's the situation. Or in this case, if you look here, terrible case. Yeah, where's the joint? And that was the situation during the operation, and then after reaming. Yeah, and it was really a tough case. And if you see here, in this case, we added a screw on the medial side and added some things on the lateral side. What was, did you see, this screw did break. It was not balanced perfect, but almost perfect, but then it healed. And that's the situation of the patient. Then he did send to me, because he goes around 27 holes of golf every day. He's retired, and that's my best handicap I ever had. Yeah? That's the result of our first cases. One late infection, revised with a spacer and reimplantation, no revision due to wound healing problems. We had 2 cysts in our first 40 cases, we filled up. Yeah? 2 patients died, but not due to prosthesis, due to other problems. But we followed all of our cases. But that is interesting. Yeah? Range of motion preoperatively, 33 degrees. At the other side, 67 degrees. Yeah? And then follow-up, 53 degrees. That means we had an increase of 61% range of motion and reached about 80% of the other side. And the VIS scale stays the same. It's always a case of 81%, but it stays the same after 1 year, 2 years, 3 years. So we did hold the results. Yeah? That's the score, the OFA score from 31 to 87. NIS score is a New Zealand score. That's like in school. 21 means you're in school notes, you're between 1 and 2. Yeah. And 43 means you're in 4 in school. That's the scores, yeah. Yes, the advantage of this new implant is aligned to the leg axis. It makes really the range of motion better. Can be implanted very loose because of the high inherent stability, very little bone loss. Revision is possible. We have done more than almost 30 revisions with other cases now, and almost 2/3 of the cases was done with the primary implant. And the scoring is better than almost all series. Yes, that's our meeting. Save the date. Thank you very much. It's our workshop was 2016. Thank you very much.
Dr. Vigneshwaran to present about a camp patient.
Good afternoon, one and all. Today I am going to present in front of you the overview of the free surgical camp what we conducted in the month of June. As soon as we got the mail regarding the free surgical camp going to be conducted by the KVS Mission and Eastward Foundation in our hospital, Sri Hospital, that the pediatric orthopedic surgeons were coming from Germany. We had announced it in local newspaper and we had distributed the handouts regarding the free camp which is going to be conducted over here. We started our registration process from May 1st. From that day, all the patients who will get benefited can be from this free surgical camp were screened thoroughly by Dr. Parthiban sir and myself. Each and every patient was screened thoroughly before the surgery dates, that is from June 24 to 29. So totally we screened 38 patients and total number of patients operated during this camp was 12 patients. Total number of limbs were 19 limbs, and apart from this 6 patients were provided prosthesis and 5 patients were provided orthosis during this free surgical camp. So Dr. Anjaman and Dr. Paul Simon sir were the main team. They came from the Germany during this camp, and this is a screening session. We had screened each and every patient who were registered during the camp previous day, and we planned for the surgery. During each day we operated nearly 3 to 4 patients. In the afternoon session post lunch we screened each and every patient who are registered for the camp, and those who get benefit from the surgery were listed out for the next day operation, and those who get benefit from orthosis were measurement were taken immediately and orthosis were provided in the subsequent days. And this is our senior pediatric consultant Dr. Jaipal sir, who screened each and every patient and provided fitness for each and every child who are going to be operated for the surgery. And these are our senior consultant anesthetist Dr. Giridharan sir and Dr. Selvaraj sir, who spent their time whole day and they stayed in the operation theatre and during this surgical camp and made this camp successful. And this is our operation theatre, the entire team during the surgery. And these are our nursing staffs in the ward, and these are our OT staffs and Dr. Selvaraj sir and Dr. Giridharan sir. And these are the children who got operated during the camp. We are going to see all these children in the first floor after post lunch session. So just showing the image of the child. So after the surgical camp was completed, we conducted a meeting for those who got benefited from the surgical camp, and these are the patients who got benefited by the orthosis, and these patients who we have provided the prosthesis for all these patients. And along with this surgical camp, we have conducted a CME program for postgraduate students on the topic Meet the Experts on Club Food, and 33 doctors registered for the workshop. We conducted a lecture and Ponseti method correction of CTV workshop for the manicure, and we also conducted a live surgical demonstration of CTV correction for neglected food, club food. This Ponseti method correction, the postgraduates are taught how to correct the club food by Ponseti technique. We have demonstrated on a newborn 2 weeks old baby, and also demonstrated on the manicure for each postgraduate. And this is a live surgical demonstration for CTV correction. And the amount what collected for the CME program was donated to the Nirmala Keshari Sishu Bhavan. So after surgical procedure was over, the story was not ended here. Each and every patient was followed up at regular interval. Wound inspection was done, and what follow protocol was provided was followed regularly according to that. Serial X-rays were taken, and regular physiotherapy training was given to each and every child. We are seeing to it, everybody were made to walk normally like others. And each and every child was came to the camp post-surgically. The camp patients were called for and custom-made process. Each and every child, we have measured the process, measurement was done individually, and custom-made process was provided to each and every child. So all the childs who came for the camp, surgical camp, operated, they are taught physiotherapy, now they are walking normally. Before ending, as my routine, I like to say one small story. Here if you see this child had a club foot. This is just an imaginary story. Child with a club foot, it was thinking, why my feet is like this, how it can be corrected. So one of the friend told, there is a free surgical camp in which the deformity can be corrected. The child got shocked. Oh, it was totally free of cost, including surgery, stay, everything. Even after surgery, the physiotherapy and everything process, orthosis were provided free, the friend told him. So he got shocked. The child came to Sri Hospital in hands with KBH machine and Eastwar Foundation. Initially he came like this, and now he was able to walk normally like other childs. Thank you.
First, I'd like to introduce myself. I am Brigadier Bajaj, retired from the Indian Army, and I was fortunate enough to run this company called Endolite India Limited for almost 19 years. This was born from the society called Ishwar, and I am also Vice President of Ishwar. It is very fortunate of us that initially when we were doing activities for Ishwar of fitment of artificial limb prosthesis and orthosis, we had got in touch with a gentleman called Dave Kelly from the USA, and Britex here was responsible for taking him down to Kerala, where we did some prosthetic and orthotic treatment to poor children in the villages there. Later on it got developed, we did some work in Chennai, we did some work all over the country, and then as God would have it, Dr. Ernst Orthner came along with one of the missions, and I think he literally fell into love with this country. He and Veronica have probably made about 20-25 visits to this country. Every year they come, they sacrifice their holidays, Christmas holidays and other holidays in Europe to come to our country and help the poor children in our country. The no words of praise can be enough for these people. We are very thankful to them. And now that I am it, we must thank Dr. Parthiban and the staff and everybody of your hospital for having hosted the last camp in the month of June, where Dr. Simmons and Dr. Anja Helmer had come here. And thank you very much. We are doing wonderful work. It is with your help and cooperation that all this happens. And I'm sure in the days to come we will keep on collaborating with each other more and more. And thank you very much for everything.
Thank you, sir. And one more request from our side is we would like to host this camp every year, sir. It will be nice if you can come down to Chennai. Yeah? It is. We also feel some social cause we have done to the society here, so it will be good.
There's a request that's pending from Bhubaneswar, from Calcutta, from Kanpur, from Lucknow, from Varanasi, from Meerut. We also have our hands full. But yes, certainly we would definitely make another visit, and if there are children and they need their assistance, most certainly.
Because after the camp, we kept receiving patients coming and asking for us. We came to know late about this. We didn't add the information early. This thing, still people are coming, sir. And in fact, one of the camp patients who came here, this patient went to one of the villages, quite very far, maybe 300, 400 kilometers away from here. They brought another child from there like this. We operated and gave them.
That's very nice of you, but well, we will definitely keep that in mind. He will have to list out his priorities.
Okay, sir. Thank you. Sir, and one more thing was like last time when we did the honoring and everything, we actually, our anesthetist, I'm sorry to say that we forgot to honor, but we have got everything ready now. I wanted you to first honor Dr. Selvaraj, and then you, sir, please honor Dr. Giri sir, please.
One of the anesthetists, along with my colleague, Dr. Selvaraj, Senior Consultant Anesthesiologist, we participated in this workshop. Actually, this was informed to us in May itself regarding the camp. So we were planning to take over the 4 days, 2 days each, and we were planning for the program to be organized. So one thing before I want to tell about this workshop, I would like to tell about this hospital per se. We are not visiting consultants, we are one of the family team of this hospital. So we didn't take it as an outsider to come and do this job. We were a part and parcel of the thing of the hospital to help them in a noble cause. And one thing before I put into the thing is, when I want to talk about Dr. Parthiban, whenever a case is fixed in this hospital for the past 2 years, the case is absolutely prepared nicely. All the investigations are completely done. Even as an anesthetist, we used to think some investigations are even not needed for that patient. So, but first important thing for him is safety purpose. And one more thing about the duty doctors, they send the investigation, everything to the WhatsApp. So when we see the patient, it's not new to us. And in case you want to assess the patient, we will be there before assessing the patients before the surgery. So everything was gone as a protocol in this place, and also the staff of the theatre, the staff people, our theatre assistants and everyone, it doesn't look like, because they work from morning till evening, whenever we come, and to say about the gratitude of this hospital members, right from the security to the ward boys to the staff members, admin, respiration, the reception people, everyone, they welcome us. And I have seen a lot of people who ask, have you had your food or anything like that. So it doesn't look like a hospital where we work in this place. And our theatre technicians and our lab people and staff, and especially our post-op care is so important in this hospital. So the protocol is being followed, and it is intimately given back to us as a feedback to the hospital by WhatsApp. And the physiotherapy team, the lab, the X-ray technicians, the ward boys, and whoever in here, I would like to personally thank on behalf of Dr. Selvaraj also. And one more thing, final thanks to the founder, Dr. Jayapal sir, and Dr. Parthiban, the owner of the hospital, or the director, and the woman behind the man always makes him a very successful, Dr. Rekha Parthiban, the managing director of this hospital. And once and all, I thank this. It is actually, it's not a felicitation or anything. Whenever we come for a function or whenever we have a celebration or a birthday or a festival, it's a greeting. I take this as not as a felicitation but as a greeting where I have worked in this place as my personal residence like that. Thank you, one and all.
Sir, I thank Dr. Giri for his wonderful talk, giving all these things, whatever we do in this hospital. And Dr. Giri is my anesthetist almost more than a decade. We both have been operating together. Thank you, sir. Thanks for the talk. I asked Dr. Vignesh to give the word of thanks.
First, I would like to thank Dr. Orthner sir and Veronica ma'am and Bridger sir from Ishwar Foundation. And I would like to thank Dr. Parthiban sir, Dr. Jaywal sir, and Rekha Parthiban ma'am, and Dr. Giridharan sir, and Dr. Silveraj sir for spending their time in this moment. And I would like to thank all our duty doctors and all our nursing staff and the theatre staff, physiotherapist, and the administrative staff, and the camera people who came to cover this entire session, and the media people also who came to cover the session, and other who came to make this event successful. Hopefully the event went on grand success. Hopefully we will conduct and host next camp in the upcoming years to treat more children, to make them walk normally like other child and make their life beautiful and happy. Thank you everyone.
Yes, thank you for the invitation to come here. I'm the first time in this hospital, but now the 20th time in India, and I did get to know a lot of different hospitals all over the country, and did see the facilities, the operation ward and the operation theatre, and it's here really a very, very good hospital. It's well organized. The hygienic situation is tremendous good here when I've seen it, and we are planning perhaps to do bigger operations in foot and ankle surgery here, especially to start with some replacement of total ankles, because in total ankles and an artificial joint it's necessary to have a very, very good facility, and this hospital is such a facility where I think you should try to do it. Thank you for the invitation. Okay? Thank you. Yeah.
We will start the total ankle project.
Okay.
Shortly we'll start it off.
Okay. Okay.
Thank you, sir.
Thank you. Thank you. Yes.
Wow.
You have seen on the wall. Yes.